Assalamu alaikum. This lecture is about morbid obesity and various bariatric procedures. Lecture outline will talk about statistics, some background knowledge. We'll discuss some laparoscopic bariatric procedure and principles of managing bariatric surgery emergencies. And we'll talk about early and late complications. This slide just to illustrate that obesity is considered a major problem worldwide, and it outweighs the global warming and bird flu and currently COVID-19 pandemic. Bariatric comes from Greek root baro, which means weight, and iatrics, which means treatment. The WHO classification of obesity, as you can see, classify people according to their BMI to underweight if they are less than 18.5, between 18.5 to 24.9 normal, 25 to 29.9 overweight, 30 to 34.9 is obesity class 1 or obesity, 35 to 39.9 obesity class 2 or severe obesity, more than 40 obesity class 3 or morbid obesity. Foresight report in 2007 looked at the problem of obesity in the UK, and it showed that the UK has been having the fastest growth of obesity in Europe, and it was costing their economy billions of pounds, and especially the NHS were having 2 billion per year in treatment of obesity. Jordan is not better by no means. In this report in 2008, it showed that 1/3 of the adult population were overweight, and probably 50% of the adults of the children were overweight, and the problem were more prominent in women, as 53% of the females were obese. And this slide just to illustrate that obesity has been growing, and the fastest growth were in the US citizen, followed by the Mexican, and followed by the UK or the British citizens. Bariatric surgery has been getting popular by the year. You can see in 2011, 158,000 procedures were carried out compared to over 200,000 procedures in 2017. And sleeve has been the commonest procedure since then. The causes of obesity is considered multifactorial, genetic predisposition, metabolic factors, psychological factors, social factors, and behavioral factors. Dietary factor probably is the most important factor, and mainly its consumption of food in high calories, sweets and sugars, etc., consumption of too much food, and lack of exercise and living sedentary life. It could be all about genes, and probably is inevitable. And this is the photo of Maradona in his 90s, and when he stopped playing, he started to become overweight, and when he done his bypass surgery, he lost weight. Medical complication of obesity, probably every organ in the body will suffer from obesity: intracranial hypertension, stroke, cataract, coronary artery disease, lung disease, liver disease, gallbladder disease, all sorts of cancers. So there is no organ is immune from obesity. And this slide just to illustrate that the relative risk is higher as the BMI increase. And you can see here with the BMI more than 40, the risk is highest. And here is just an expectation of the diseases linked to obesity. And you can see that type 2 diabetes is expected to be the highest increase if obesity is not being managed properly. So why we do surgery? We know from statistics that hypercholesterolemia will resolve in probably 2/3 of the patient, hypertension as well, 80% or more of metabolic syndrome, and diabetes type 2 will resolve after doing bariatric surgery. In addition, the quality of life and mortality also will the quality of life will improve, and the mortality will reduce after weight loss following bariatric surgery. So bariatric surgery is effective, and in this randomized control study, when we have 80 patients involved, lab band resulted in greater excess weight loss at 2 years versus intensive diet, lifestyle modification, and medical therapy. And the difference was statistically significant. Patient receiving surgery such as lap band or Roux-en-Y gastric bypass had up to 77% excess weight loss at about 10 years after surgery, and their overall mortality were up to 40% lower in 7 to 10 years post-surgery compared to BMI matched patient not receiving surgery. And this is another evidence when we have randomized control study utilizing 60 subjects with type 2 diabetes, and they had adjustable gastric band, and there was 73% remission of diabetes compared to only 13% in control group who received only diet modification, medications, and exercise programs. Bariatric surgery. We've seen that bariatric surgery has been, the numbers has been increasing over the years with about 200,000 procedures done in 2006. This slide will reiterate the benefit of bariatric surgery over non-surgical approach. Behavioral changes resulted in only 4% of weight loss compared to 8% of weight loss using pharmacological intervention. 90% of obese patients treated non-surgically will relapse within 5 years. Bariatric surgery probably is the only approach to achieve significant and sustainable weight reduction beyond 1 year. Sign guidelines is a nice guidance to tell us who will benefit from bariatric surgery, and in summary, people with BMI of more than 35 or with one or more comorbidity will benefit from bariatric surgery. To achieve the best outcome from bariatric surgery, a bariatric multidisciplinary team should be available to manage such patient, and the bariatric MDT members include bariatric surgeon, anesthetist, endocrinologist, dietitian, bariatric nurse, etc. Patient expectation should be reasonable, and the patient should be aware that they will not become models after surgery. it will only reduce their weight and eventually reduce their risk of having the obesity comorbidities. And the surgical options available: Roux-en-Y gastric bypass, gastric band, sleeve gastrectomy, gastric balloon, and probably these are the common procedures. The less common procedures: mini gastric bypass, single anastomosis duodenal ileal bypass, and duodenal switch. The principles of treatment of patient with bariatric surgery. Abdominal pain in bariatric patient is similar to any other patient. You should take detailed history, type of surgery, when it was done, where and by whom, any complication noted during the surgery. Unstable patient with worsening sepsis, take them to theater. Do not delay. The bariatric patient have unique challenges, such as that their clinical presentation of peritonitis is subtle compared to other patients. They have difficult veins. They might have difficulty in getting their blood pressure measurement due to their large arms. The bed capacity could be also a problem, CT scan capacity as well, and the surgeon looking after them might be unfamiliar with bariatric surgery. Early complication which happen less than 30 days after surgery include bleeding, leak, VTE, stomal stricture, stomal ulcer, gastric outlet obstruction, and intestinal obstruction. Late complications such as gallstone, stomal stricture, stomal ulcer, portal vein thrombosis, intestinal obstruction, leak/fistula, dumping syndrome, and nutritional deficiencies. Acute abdomen in bariatric patient. Always think about leak, leak, leak. Then you can think about bleeding or intestinal obstruction. Leaks in general. Any patient with abdominal pain in the first few weeks after surgery, assume there is leak until proven otherwise. Signs of leak include fever, tachycardia, and leukocytosis. Contrast study or CT scan might miss leak. Free air and fluid seen on imaging study at 1 week after surgery is not normal. Should think about leak. If you are in doubt, take patient to theater and laparoscope them. So this is Roux-en-Y gastric bypass, and here, just to be familiar of the anatomy, you make a small pouch of the stomach and detach from the rest of the stomach. So this will be called the gastric remnant, and this is the gastric pouch, and you anastomose the gastric pouch to this small bowel, and this is called the alimentary limb. The gastric remnant along with the duodenum and about 1.5 meters to 2 meters of the jejunum is called the biliary limb, and these will be joined and they form here the common channel. So this is an imaging study, and you can see here a leak from the gastro-jejunal anastomosis. So leak after Roux-en-Y gastric bypass. Gastrojejunal anastomosis is probably the most common site of leak. Jejunal anastomosis, stable line in the residual stomach or gastric remnant, or a missed enterotomy. How to manage it? In a stable patient, you can do percutaneous drainage, endoscopic stent placement, fibrin glue injection, endoscopic clip. Unstable patient, you have the option of laparoscopic versus open intervention. Luminal bleeding after Roux-en-Y gastric bypass. You can control it by endoscopy, by clipping, or any other method of endohemostasis, or you can do laparoscopy if the bleeding from the jejunal anastomosis or if from the gastric remnant. Here you can see that the gastric remnant is dilated, the small bowel is dilated, and here we have a collapsed small bowel. That indicates adhesive bowel obstruction. Causes of intestinal obstruction after Roux-en-Y gastric bypass, commonly adhesions or internal herniation through Peterson space, or internal herniation through a mesenteric defect, technical error with a closed loop or twisted loop, narrow occluded jejunal anastomosis, or a blood clot at the JJ anastomosis, or port-site hernia. The manifestation of the obstruction: if the obstruction was at the biliopancreatic limb, the patient might suffer from upper abdominal pain, deranged LFT, distension of the gastric remnant. Obstruction of the alimentary limb, the patient might have inability to tolerate oral intake with excessive vomiting. If there is obstruction of the common channel, bilious vomiting is the main presentation. Here we can see the twisting of the bowel with twirl sign indicating twisted bowel. Here, just to show you the Peterson space through which internal herniation can happen, or internal herniation through a defect in the mesentery. This is a CT scan of a patient with dilatation of the gastric remnant, and you can see here the contrast seen in the gastric pouch indicating gastric remnant dilatation. We have either acute or chronic dilatation of the gastric remnant. For the acute dilatation, the causes could be obstruction at the jejunal anastomosis, biliopancreatic limb, or the common channel, or a clot at the stable line, or technical error. CT or operative decompression is the treatment of choice. Chronic dilatation could be due to peptic ulcer, vagotomy, cancer, or gastroparesis, and the duodenum remains undilated. On this gastroscopy, you can see here an ulcer, and this is called marginal ulcer. It happens up to 15% of patients with Roux-en-Y gastric bypass. Management non-operative with dietary modification, stop smoking, stop the offending medications such as NSAID, start PPI. Surgical with revision of the anastomosis. Gallstones happens to about 1/3 of people undergoing bariatric surgery. Prophylactic cholecystectomy is a controversial. Patient presenting with common bile duct stones after Roux-en-Y gastric bypass, you could do laparoscopic common bile duct exploration and stone extraction, or you could do transgastric ERCP or percutaneous transhepatic biliary drainage. This slide shows gastric band, and if the gastric band is overinflated, or there is a slippage, or there is a bit of edema, the patient might have dysphagia and inability to swallow. This is a contrast study with a patient with overinflated band, and you can see here that the esophagus is overinflated and dilated, and there is just a trickle of dye passing through the band. And this is another contrast study showing the same with overinflated band. If you had an overinflated band, the treatment of choice is to deflate the band, and the way is to use an uncoring Haber needle. The normal needle might damage the band and make it useless. Here again another photo. That's the band here, gastric band, which is overinflated. But here you can see the position is a bit different. This is the band, and this is what we call O sign, and here the band, and you can see that's the angle between the spine and the band is obtuse, indicated that there is band slippage. You can see that this is the normal position of the band, and the vertical line is like that. So the angle between the band and the vertical line should be acute. If there is slippage, you can see that this is the band here. When it slipped, this acute angulation is lost, and that's indicative of band slippage. When patients have band slippage, their presentation is pain, dysphagia, gastric outlet obstruction, and gastric wall necrosis. How to manage it? You need to deflate the band and laparoscopy. Laparoscopy, you could reduce the stomach, and that will avoid opening the band. If you can, then you have to open the band, reduce the stomach, and reposition the band. Sometimes when you do opening of the band is damaged, so you have to remove the damaged band and consider another bariatric. Probably the commonest bariatric procedure done nowadays in Jordan and worldwide is sleeve gastrectomy. And the slide just to show you how it is done. This is the esophagus, stomach, this is the duodenum, and this is the jejunum, and you could see that what we are doing is stapling the stomach, making a narrow sleeve, a narrow tube of the stomach, and the rest of the stomach is removed. In this contrast study, you could see a bit of dye coming out from the gastric sleeve, indicating leak. Usually it happens on the proximal end of the sleeve due to the fact that there is poor blood supply there, thin tissue, and narrow sleeve. Management of leak after sleeve: if the patient is unstable, take them to theater. If they are stable, consider percutaneous drainage or endoscopic stent. Bleeding after sleeve gastrectomy: luminal bleeding, you can control it by endoscopy or surgical re-exploration. If it's intraperitoneal, then surgical exploration is mandatory if the patient is unstable. This slide to remind us about acute medical emergency after any type of bariatric surgery. That's thiamine deficiency or B1 deficiency. It could present as dry beriberi with the patient emaciated and neurological signs and symptoms, or wet beriberi due to the acute right-sided heart failure resulting in anasarca, generalized edema. If this is not treated, it could progress to Wernicke's encephalopathy with ophthalmoplegia, confusion, coma, and death. You can see that thiamine deficiency can happen at any type of bariatric surgery, such as the gastric band, gastric bypass, biliary-pancreatic diversion, or duodenal switch. Macronutrient deficiency usually happen with the duodenal switch and biliary-pancreatic diversion, and the least type of, or the least common to have micronutrient deficiency is laparoscopic adjustable gastric band. Here, this slide just to summarize how to manage patients who come with or who present with acute abdomen. If they are unstable with generalized peritonitis and they are rapidly deteriorating, to theater immediately. If they are not, then there is a role for imaging with CT or gastrography or water-soluble study. If it's negative, then you consider endoscopy or laparoscopy. If it shows, gives you any positive finding, such as leak, bowel obstruction, or abscess, you manage accordingly. Any patient, before you take them to theater, you need to try to contact the bariatric surgeon who've done the procedure and find out as much information as you can. Don't get misled by falsely negative radiology. And if you want to operate, you should make sure that you have the proper instrument, such as proper ports, proper long laparoscopic instrument, liver retractor, the split leg OR table, etc.